Okay, let's take up the next patient. So he is an elderly male and he is having a history of CKD. Underline that CKD. Now he is having fatigue, weakness, pallor, HP is 9. So ultimately he is inferring that there is anemia. And his serum ferritin is normal. And serum erythropoietin levels are low. What do you want to do? That is what he's asking. So a case of CKD with anemia, what do you think is the cause? It's anemia of chronic disease. See, CKD is an inflammatory condition, pro-inflammatory condition. One thing, and there is deficiency of erythropoietin in the kidney disease. Erythropoietin, the main source is kidney, right? So your erythropoietin is low and chronic inflammatory disease, this patient will have anemia. Initially, this anemia is normochromic, but as the disease progresses, it will go into microcytic anemia. He has, because the most common is normocytic and microcytic, he has not mentioned it, but he has done the serum iron. Mostly it could have been microcytic anemia. That is why he has done serum iron. Serum iron is normal. So definitely it's not iron deficiency anemia. In iron deficiency anemia, the first parameter to decrease is only the serum ferritin. If serum ferritin is normal, you're not considering it as iron deficiency anemia. And there is decrease in serum erythropoietin levels. That is what we expect in CKD, right? What is your management? So here the HB is 9. Are you going to do blood transfusions? No, HB 9 is fine. If there is severe anemia less than 7, I'll go for blood transfusion. Okay. Are you going to give iron, oral or IV iron to this patient? No, because the ferritin levels are normal. I'm not going to give extra iron to this patient because it can lead in iron overload. Are you going to give erythropoietin to this patient? Yes, that is an option. I can give erythropoietin to this patient. So he's asking what is the initial management. So he has also given a picture of recombinant human erythropoietin. So this is what he's using in this case. Most appropriate next management is erythropoietin stimulating agents. Okay, we discussed why not to give blood transfusion, why not to give oral supplementation. Then B12 supplementation. You want to give B12 tablets to this. I've seen most of the interns, a case of anemia comes to them, they'll write IDA. Sorry, they'll write tablet iron folic acid, yeah, IFA they'll write, and tablet MBT. These prescriptions I've seen a lot. So just don't give iron simply for anemia. Evaluate it. If it's microcytic hypochromic with the low serum ferritin, give iron. Just microcytic anemia is also not an indication to give iron because there are a lot other causes. Most common is iron deficiency in our setting, but you have to rule out other causes also. Do an iron profile, confirm it's iron deficiency, then give iron, and then don't give simply multivitamins to the patient. If it is vitamin B12 deficiency, this patient can have macrocytic anemia. We do not know which type of anemia is it. But other than macrocytic anemia, he'll have other features like hyperpigmentation of the skin, like he'll have peripheral neuropathies or any neurological manifestations, and the magenta tongue. All these are the manifestations of B12 deficiency, right? All those things could be there along with this. If you suspect B12 deficiency, then you can give B12, but here, no, there are no other signs and symptoms mentioned. So the appropriate therapy is erythropoietin stimulating agents. So CKD on or with or without dialysis, anemia is there, you can choose erythropoietin stimulating agents. But before giving erythropoietin stimulating agents, you have some checklist. One thing is the HB should be less than 9. If it's more than 9, if it's 10, 11, there is no point in giving ESA. Why I'll say. And your iron should be normal. There is iron deficiency and you are giving erythropoietin stimulating agents. There are new RBCs, but they are microcytic. What's the point in giving erythrocytic stimulating agent? So whatever the iron deficiency is there, correct it, then give erythropoietin stimulating agents. So these are the checklist. HP should be less than 9 and iron should be normal. Only then I'm going to go for erythropoietin stimulating agents. What happens if HB is 10, 11? I want to make it to 12, 13. I'll give erythropoietin stimulating agents. What will happen? The thing is, the most dreaded side effect and the most common side effect of erythropoietin stimulating agents is the thrombosis, prothrombotic condition. This patient will land to you with CSVTs because it's prothrombotic. Our cutoff is 9. For suppose the HP is 7, you started them on erythropoietin stimulating agents. Now it's reached 9, stop them. Enough. So more than 9, you're not going to give erythropoietin stimulating agents. That thing should be noted. Okay, the same thing is given here. So coming to the formulations, there are different formulations. Eptoin alpha, darbepoetin alpha. So the advantage with darbepoetin is it's long acting, so less frequent dosages. Coming to eptoin alpha, we will be giving 5 to 100 units per kg. And that dose will be 3 doses per week. So almost every alternate day he should get that, and it is subcutaneous or IV. IV is better, but if the patient compliance is also important. For every alternate day, he can't come to your tertiary center if you're working there. He'll take at the nearest primary health center, subcutaneous. And darbepoetin alpha, it is 0.45 micrograms per kg. It's once weekly. Okay. These are erythropoietin stimulating agents. This will stimulate the erythropoietin. There is one more drug called daprodustat. This is a newer FDA approved drug for case of CKD with anemia, and this is endogenous erythropoietin stimulator. How it will inhibit hypoxia inducible factor prolyl hydroxylase. That is the mechanism of action. It will inhibit this HIF pH inhibitor and endogenously stimulates EPO. So daprodustat is new FDA approved. So that is about anemia of chronic disease in CKD. How are we going to treat? So it's a young man presenting with fatigue. Again, fatigue, jaundice, dark colored urine. Okay, along with fatigue, here we have an extra symptom of jaundice and dark colored urine. And he had recent consumption of fava beans. Okay, on examination, there is pallor. Okay, anemia, jaundice, and dark colored urine, which has followed fava bean consumption. What do you think it is? And laboratory investigations are showing anemia. Yeah, very good. But there is elevated reticulocyte count. So this is anemia with reticulocytosis. And a peripheral blood smear was performed, and this is the image he has shown us. And this is the routine staining. If you look at the first picture, in the routine staining, how do you see the RBCs are? They are like somebody has bitten them, right? They are called bite cells. And if you look at the special supravital staining, wherever you have seen the bite in the normal staining, there now you can see some bodies. They are called Heinz bodies. So these Heinz bodies are nothing but oxidized hemoglobin, which is stained on the supravital stain but not stained on the routine stain. So in routine stain, you are seeing them as bite cells, which are empty, and in the special supravital staining, you are seeing them as Heinz bodies. That's it. And along with this, there is this evidence. This is nothing but G6PD deficiency. So this is a 25-year-old male Only after exposure to some oxidative stimuli, that is fava beans, only then he had hemolytic anemia. That is anemia with jaundice with dark colored urine. There is intravascular hemolysis, right? So this is intermittent. This is G6PD deficiency. Why is it not autoimmune disease or autoimmune hemolytic anemia? First thing, your autoimmune hemolytic anemia is predominantly extravascular, seen in young males, of course, young females, of course, rarely males are also affected. And there are cystocytes on the peripheral smear. And there is ICT, DCT positive. Coming to G6PD deficiency, yes, it is a hemolytic anemia, which is intermittent on exposure to oxidative stimulus. Because it's an enzymopathy. G6PD is an enzyme, right? So it's an enzymopathy and there is no spleen here. That is, splenomegaly is absent. Whereas hereditary spherocytosis is a RBC membrane disorder because of the defect of ankyrin followed by band 3. There is hereditary spherocytosis. It's a hereditary condition where the RBCs are assuming a shape of spherocyte. They are all autosomal recessive conditions. Here, this patient from childhood itself is be having hemolytic anemia, and there is massive splenomegaly here. Whereas sickle cell disease, in G6PD deficiency, after exposure to oxidative stimuli, there is hemolysis. In sickle cell disease, when exposure to hypoxia, when you are exposed to hypoxia, this patient will have sickle cell formation and hemolysis. And in peripheral smear also, you can see sickle cells. The cells are in the shape of sickle. The phenomenon is called sickling. Yes, this typical presentation. So in hemolytic anemias, he can give you the evidence of anemia and jaundice. He has to specify the indirect bilirubin has increased, not the direct. That he will specify. And if there is dark colored urine, it indicates that there is hemoglobinuria and it's seen in intravascular hemolysis. In extravascular, you won't be seeing hemoglobinuria. Hematuria is different, RBC in the urine. Hemoglobinuria is iron, heme in the urine. So there will be no or mild splenomegaly. But here there is massive. Okay. So the same thing is given here. So you have seen that exposure to fava beans, there is oxidative stress. So what other oxidative stress are seen in G6PD deficiency? Because the main mode of management is you will advise the patient to avoid those oxidative stresses. Oxidative stress, which will precipitate intravascular hemolysis in G6PD deficiencies. The most common is infections. And the next common thing is drugs, followed by food. Food is your fava beans. Infection is most common and any infection can cause. And coming to drugs, there are multiple drugs which can cause, that is starting with rasburicase. Rasburicase is a uric acid lowering drug. We'll be using that in tumor lysis syndrome, right? Next, antibacterials like sulfonamides and nitrofurantoin. Next, anti-leprosy drugs, dapsone. Anti-malarial drugs. Which anti-malarial drug can precipitate hemolysis in G6PD deficiency? Primaquine. and a newer drug, tefenoquine. And methylene blue. So you can remember this in this way. So infections, drugs and foods. Drugs are very important. They will mention this drug as a clue point in the question, or they can ask that in the options also. So this question can be combined with pharmacology also. Clinico-pharmacological question can be framed. He can give this image and he can give the options which drugs can cause this. Anyways, they can frame the question. We should know the concept. Next question. Is a 45-year-old male. He's having fatigue, recurrent infections and bruising. Did you observe he's having pancytopenia? Because of anemia, he's having fatigue. Because of neutropenia, he's having recurrent infections. And easy bruising is because of thrombocytopenia. So basically, elderly male with pancytopenia. The laboratory investigation is also revealing the same. So pancytopenia, there are many causes, and how are we approaching pancytopenia is we'll look at the bone marrow. Hypocellular, the differentials are different. Hypercellular bone marrow, the differentials are different. And pancytopenia with hypocellular bone marrow, most important thing to be considered is aplastic anemia. And hypercellular marrow is MDS. Myelodysplastic syndrome. See, your aplastic anemia and myelodysplastic syndrome both are presenting with pancytopenia, but aplastic anemia, your bone marrow is hypocellular. Literally, your bone marrow is being replaced with fat globules, whereas hypercellular in MDS. So, look at the bone marrow picture. What can you see? All fat globules are there. Your bone marrow is literally replaced by fat globules and it is hypocellular. Probably it's aplastic anemia. So what is the initial treatment you are going to give? Your bone marrow is replaced by fat. So what you should do? You should go for bone marrow transplant. If the patient is young and fit enough, you have ruled out all the secondary causes. The best thing is to go for allo-BMT. Allogenic bone marrow transplant. Do you think the erythropoietin stimulating agents will work here? The bone marrow is only hypercellular. It's replaced by fat. There are no precursors only. Whom will this erythropoietin go and stimulate? Nobody. So waste. And if the patient is not fit for bone marrow transplant, you can give anti-thymocyte globulin plus steroids. That is one of the choice, but not initial choice. And platelet transfusion, how is it appropriate? It's just symptomatic management. Platelets are low, you're giving it, that's it. It's just stabilization, that's it. The patient is bleeding, you're giving platelets. Just to prevent bleeding, you are giving platelets. It's not appropriate management. So allo-BMT will be the initial appropriate management. If the patient is not fit for that, you can go for anti-thymocyte globulin and you can also give cyclosporin. That is the management of choice for aplastic anemia. Whereas for MDS, myelodysplastic syndrome, so we'll see whether it's low risk or high risk. Low risk, we won't go for any management. If there is 5q deletion, we can start him on lenalidomide. If we're high risk, there is not much treatment. If the patient is having anemia, you can give erythropoietin stimulating agents and just support him. That's it. And if there is a theory called MDS related AML or secondary AML arising from MDS. So your MDS is like a pre-malignant condition which can progress to AML. If it's progressing to AML, you can treat it like AML only. You'll give induction chemotherapy. This is the difference of management. So if it's Aplastic anemia, your management is different. MDS, the management is different. So pancytopenia, you should be able to find out the cause first and then treat. So blood is low, just giving HP is low, just giving blood transfusions. Platelets are low, just giving platelet transfusions. So your lineages are low, just giving growth factors is not going to do anything in this.